There was a time when you went into a doctor's room and their word was gospel, it was final. But should we be more active? Should we be more collaborative, maybe more confrontational with our doctors? Should we be less passive and collaborate with them? This is the MoneyMakers. I'm Bruce Whitfield. Tonight I'm joined by Professor Morgan Chetty. He's chairman of the Independent Practitioners Association Foundation to talk about why person-centred care is the future and why he believes it'll benefit healthcare not only in the country but it's a worldwide trend as well. It'll help the medical aid schemes, patients at large, and maybe even feed international health. That is the plan anyway, isn't it, Dr. Motsoaledi? It's nice to see you, Dr. Chetty. Now listen, this is work that you've been doing as an academic. It is work that you're doing on behalf of practitioners. Is it work that you're doing for the Department of Health? Have they asked you to come up with recommendations?
No, not in this particular field. Not in this particular field. I have been on the National Health Advisory Committee looking at the ideal clinic development, but this particular topic is not. And I must add, I'm a little disappointed because patient centricity, person centricity is actually on the agenda at the moment of all institutions in the world, all governments in the world.
Forgive me for being really stupid about this, but patient centricity surely is what health systems are about. If the patient is not at the center of the system, then why do health systems exist? Their purpose is to heal the patient.
Yeah, I think we've adopted and we've come from a system where the healthcare system revolved around institutions. It revolved around hospitals. It was hospice-centric. It was very provider covering for professional centric, and the patient was outside the system, right, totally outside the system. And then in 2001 and then later 2009, the Institute of Medicine in America put out what we call a landmark document called Crossing the Quality Chasm. And in this landmark document, one of the 6 attributes to good quality, cost-effective healthcare was patient-centered care.
It sounds like it's been a policy designed for idiots, because to my mind, as a as a customer of healthcare, I would hope I'd be at the center of it. Because if I'm the patient and I don't come back for a second round because the doctor messes up, the doctor ultimately loses out. I've got to be at the center.
You've got to be at the center, but let's see what we've inherited. What we've inherited is a patient who is a passive recipient of information.
And care.
And care. And also, the way healthcare is being delivered in this country and many parts of the world, it's a unilateral, a unidirectional movement of information. It comes from an elitist professional who sits outside the system, giving information down to the patient who doesn't sometimes understand what it is. So he's not engaged, he's not part of the process, but he's getting this information down. So he's a passive recipient of care. With patient centricity and patient-centered care, what we're trying to do, we're trying to move the patient to become a healthcare activist.
Which is why there's a distinction between this term of patient centricity, which is beginning to feel a bit dated, and something you talk about, which is people centricity. Now, to the layman, it sounds like it's one and the same thing. Your argument, though, is as active citizens, as collaborative citizens, confrontational citizens, participative citizens even, that dynamic in the healthcare relationship should change.
It definitely must change, because I think the problem is that we got to move, as Margaret Chan from the WHO said, we've got to move away from this concept. Well, it came as a very positive concept, patient centricity. But we're looking at it now as person or people centricity. And the reason for that is when a patient comes into your rooms, it's a bit too late. He's got the disease entity, he's come for treatment. If we focus on person centricity, we keep the patient away from becoming a patient. So the whole emphasis is going away from curative care, is going to wellness, is going to keep the patient fit. It's more preventive, promotive care that's the answer to the 21st century.
I'm almost expecting you to pull out a Discovery business card right now, because that feels a lot like what Vitality's been trying to do for the last 15 years.
Exactly. I think Vitality did it in the private sector. They made a success for it in the private sector. They've implemented it in other parts of the world, and it's working. But I think because we don't have a organized system of putting this into effect, it's not happening at the moment. So I agree with you totally. In fact, this word patient centricity has been a terminology that's been there for decades. It came into the healthcare lexicon, it came into academic lexicon in 2009 by this Institute of Medicine document. And what it said there, that healthcare must be respectful and responsive to the patient's needs, the patient's preferences and patient's values, and the value that the patient brings to it should guide clinical decision making. So suddenly we find there's a new person in the center of healthcare, and that's a patient.
Now, could you, I mean, the argument for Vitality, if you talk to Adrian Gore about it, is ultimately it reduces the Discovery Medical Scheme's liability, because if you have healthier members, they're less likely to get sick. And in the unfortunate event that somebody does get a terminal illness as a result of genetics or environment or whatever it might be, through no fault of their own, then there is a medical aid system there to provide backup. Is it possible to take a model like that, and it can't be exactly the same, and put it into a public healthcare system where the incentives are very, very different between medical service providers, patients on the one hand, or people on the one hand, and in a Vitality system where you're able to incentivize behavior with price?
I think you can. I think you can. I think you're going to find that, you know, if you look at the national health system,
which one? Ours here?
Ours here. Okay. When it does come about, when it does come about, it's going to take a long time to get to where we want to go to. If you look at the NHS in the UK, in the NHS in the UK, people are incentivized to stay healthy. Patients are incentivized to stay healthy and to stay out of the healthcare system. And I think the problem is that why aren't we getting there very quickly? Is because the way the construct is at the moment, the patients are oblivious. They do not know how they should engage. A patient feels that if he is confrontational or asks questions or gets involved in it, it's going to be confrontation to the healthcare provider. So,
but this is a person who has spent at least 7 years of their lives just going through the normal course of study. They get to the end of a year of 7 years of study. They might then choose to specialize, which takes, another 2 years perhaps. Then there's years of experience under the belt. And snotty patient or customer comes in through the door and says to you, I'm going to tell you how to do your job. Doctors, in my experience, tend to take offense at that.
I agree, but I think this is not what person centricity is. We don't want a patient to walk in and demand services. We want a patient to walk in, and the doctor must have a mindset change. And I'll talk about it just now. In the mindset change, he must engage and empower the patient.
Debating what the structure of education, health and every other sector of society should be for the last 22 years. We've mucked up education royally. We've not done a great job in healthcare. The Mandela government inherited a system designed for the few with the many excluded. It's been a shambles. Is there not a risk that we're going to end up talking about this for the next 22 years without the implementation of a better and more equitable health system for everybody?
I think it's 100% correct. I think the problem we have is, I think the government's heart is in the right place. I think the government's intention is correct.
But its arteries are clogged.
Yeah, I agree with you. I think we must sit back and say, what resources are there at the moment for us to speed track not only national health, but to speed track this whole thing of patient sensitivity or redesign. And I think you can only do it in one way. Let's take the resources that are out there. Example, the Discovery Vitality, the quality initiatives, the resources that are sitting in the private sector. I think government needs to harness those resources.
But the moment you suggest that, the private sector digs in its heels and says, hold on a second, we've got a globally competitive, world-class system here operating alongside a dysfunctional system. You can access our resources. You want to do what? They're ready to cooperate. But government says it wants to cooperate with the private healthcare sector. The private healthcare sector, it wants to cooperate with government. But they've got fundamentally different ideas of what their cooperation should be, and they pass each other in the night.
100%. I think, you know, if you talk to everybody in the private sector, no matter the fact that we are in the top 5 in the world in the private sector has opened its doors to the fact that we want to be part of that solution. We don't want to be left out of the solution. So I know at the moment we have different levels of the conversation, but I think it's time we sat around a table and try another. It happened in the Netherlands, it happened in Sweden, it happened in Ireland, it happened in Australia, where they
all with a demography that is a lot flatter than South Africa's.
It is a demography flatter, but the important issue is they went and regulated the private sector, right? And by regulating the private sector, for them the regulation probably was at a different level. Ours has got to be at a totally different level. I think you're going to regulate the private sector and then start this incrementally. I have one notion which I try to sell and won't be bought by anybody. I think we should be concentrating on the indigent and the poor and people who don't have healthcare. We should be looking for services. Then we're dealing with fewer people. I think we shouldn't be allowing free healthcare to a person that's able to pay for his healthcare at the moment. And the present system says 55 million people are going to, on one day, walk into the system and get it free. I think that's going to be more disadvantageous to anything else. And
we have to leave it there, unfortunately. But you've sold, you put your sales pitch into it. Should only the poor, should there be a means test for free healthcare? Certainly, it's a logical solution to a seemingly intractable problem. Professor Morgan Chetty, who's chairman of the Independent Practitioners Association Foundation. It's a big title and you need strong lungs for that one. More challenges, more problems, more difficulties, more issues to argy-bargy about in the not too distant future. For now, though, have yourselves a very good evening and don't develop a cough and need to go to a public hospital overnight. Good night.